Hello, everybody. Welcome back to the Incubator Podcast, live at Hot Topics in Neonatology. We are joined by Dr. Cindy McEvoy. Dr. McEvoy, thank you for being on the show. It's going to be hard for me to call you Cindy because I'm a big fan of your papers.
Oh, my gosh. Thank you. But please call me Cindy.
Oh, I'll try.
Okay.
It's a pleasure to have you on. You're a professor of pediatrics in the Division of Neonatology and the director of maternal child health and research in the pediatric department. You're the director of neonatal research at Credit Unions for Kids Professor in Pediatric Research at Pape Pediatric Research Institute in Portland, Oregon. You're involved in a variety of ways throughout the conference. And I'm just wondering, for the people who are back home who would love to know what are the topics you're tackling this time around at Hot Topics, what are some of the takeaways you would like to leave them with?
I think, first of all, I wanted to emphasize that, premature infants all have altered lung development, and we know that an individual follows along a pulmonary function percentile that's established very early in life. And if an infant's born preterm, they have altered lung development. So they're never going to reach their maximum as a young adult, and they're going to be more predisposed, even with a normal lung function decline after 22 years of life, to be at increased risk for respiratory disease as they age. So I've really focused on that early time point, as that we take care of as neonatologists, those preterm infants, to try to maximize their lung function early on. And so at Hot Topics, I talked about the fact that even though we know early CPAP has been shown to decrease lung disease, if we put babies, even the smallest ones, as we can, on CPAP right from delivery and don't put them on mechanical ventilation, that decreases lung damage. We still don't know how long we should keep those stable preterm infants on CPAP. So we looked at trying to define the optimal duration of how long we should keep the babies who are stable on CPAP to really optimize their lung growth and development.
I see. I mean, there's a lot of conversations about trying to, like you said, trying to keep babies on CPAP up to like a certain time point, whether it's 32 weeks or even longer. When people are concerned about, I would love to keep the baby on CPAP and I would love to have the baby on CPAP right from the get-go, but it's difficult to manage these infants, especially on the smaller end of gestational age, on a modality like non-invasive CPAP. What are your responses or your advice for these?
I think try to optimize your CPAP application as well as possible from the very beginning. And we use bubble CPAP. I think learn how to use one application as well as you can in your unit. And again, we use bubble CPAP with the Hudson prongs. Look at the interface. Make sure that you have really optimal CPAP delivery. And again, we looked at it more from the standpoint of, is the duration of CPAP and the mechanical stretch that the CPAP is giving to the infants, is that also continuing to stimulate lung growth? And we were also able to show that the babies had increased alveolar volume at 6 months of age and also lung diffusion capacity. So at 6 months of age, if we kept them on the CPAP longer in the NICU.
And it's interesting because we did a whole series on flow versus pressure, and that if you're hooking up your bubble CPAP, but you're not using the proper interface, you're not delivering pressure and you're not delivering CPAP. And I think it's a very important point that know the interface, get the reps back in your unit to show you how to use this optimally to deliver, basically to give the baby what you intend to give. Because I think a lot of times we say, oh yeah, this baby's on CPAP of 5. They are not on CPAP of 5. They are not receiving nearly close to a PEEP of 5. And I think that could be, and then you say, oh, they failed CPAP. And it's like, that's not true. They didn't fail CPAP.
I think you have to be very patient and you have to look at just very small details and do a lot of education with the bedside caretakers are critical. And you have to get them on board.
Yes. I think, that makes all the difference. Their understanding of how much seal, what kind of seal, the right fit, the right size, the readjustments, or noticing when the seal has become suboptimal. That's make or break it. And we don't really have any control over that except, like you said, education. So what sorts of things do you do in your unit to help optimize that at the bedside?
I'm at the bedside very frequently, talking to the bedside caretakers, doing continuous re-education, and then talking about our research studies and how important it is that stretch probably from the CPAP in terms of stimulating the lung growth and development. And also during this study, which I didn't talk about during the presentation, was we actually quantified these little dips in oxygen saturation that happen with a second pulse oximeter, so we could capture them very granularly. And even though both of our groups of randomized patients were on room air, the ones that were on the CPAP and room air had significantly decrease of these intermittent episodes of hypoxemia, which have been linked to
Bad neurodevelopmental outcomes.
Yeah, exactly.
Yeah, I mean, every
Exactly.
time if you do PubMed search for intermittent hypoxemia, like these are terrifying. Like, oh my God,
Yeah.
you're going to be at the bedside all the time trying
Yes,
to compensate.
yes, yeah.
But let me ask you then, what kind of gestational ages are we talking about? Because I think it's important today when we have an active resuscitation attempted at 22 weeks that we understand like what kind of population, because like you said, they're all very different.
Yes. Well, for our study, we were focusing on babies who were born at actually less than 33 weeks of gestation who were placed on CPAP from the get-go for respiratory distress. And then when they met specific respiratory stability criteria, we randomized them to the 2 extra weeks of CPAP versus at our institution, when they're stable, we take them off CPAP right to room air so we don't prolong any oxygen delivery. And the babies who got the 2 extra weeks were the ones who had improved pulmonary function development. When we tested them in the nursery, they had larger lung volumes. But when we tested them at 6 months of age, they had larger lung volumes, better lung diffusion capacity, so more growth of capillaries. But they also had improved forced expiratory flows, which has linked to wheeze.
And I'm assuming then that as you get to the edges of viability, whether it is 22, 23 weeks, then I guess then it's less consistent to be able to maintain these infants on non-invasive CPAP for these extended durations, especially early on, I guess.
Yes. Well, and again,
You're really looking at the back end.
I'm
though.
looking at the back end of it.
It's keeping them on 2 weeks longer than you normally
Exactly.
do.
So if you look at the Columbia experience, has been shown in this conference and talked about, they put the patients on bubble CPAP from the very beginning and have been very effective and were shown to be a unit that had the lowest incidence of bronchopulmonary dysplasia. But they also keep their infants on CPAP very long. Like I laugh, I think I envision them rolling the baby out at discharge and they're taking them off CPAP. And the question I had that came up in my mind for the study was, it could be that the early use is good in decreasing BPD, but what about that prolonged use? So that's what we really focused on in this study, looking at the prolonged use.
Absolutely. That makes sense. And this is something that is being echoed by other groups around the world, I would say. I mean, the WHO is looking at, in this case, they're looking more at the early use of CPAP, but the folks in Canada as well are, this is something that is becoming quite apparent to a lot of different groups around the world as well. So, this is quite amazing work.
And so tell me then about the babies that are kind of moderately preterm. We have some colleagues that, they're 29, 30, 31, 32 weeks. So they say, this kid doesn't need CPAP. The kid's doing great. What do you think about that group of babies?
Put them on CPAP. If they were in utero, they would have fluid-filled lungs.
All that back pressure we forget about.
Yes, they would have fluid-filled lungs, and studies have shown that creates probably a transpulmonary pressure of about 3 to 4 centimeters of water. So giving CPAP with the air distension is going to mimic that, and it's likely very important for, as we've shown, lung development and blood vessel development.
The last question I have for you is, I think something that people may be wondering, when you do that, you should not assume that there's a ladder to climb down from CPAP. I think a lot of people say, well, if they're on CPAP, then I have to wean them to high flow. Then I have to wean them to... You could take these infants at a designated time point and take them on room air directly and not have to go through this de-escalation nonsense that's a lot of people sometimes feel they're subjected to. And I think that's a big deal for units because so if I can go from straight a CPAP of 5 to room air, then that's a game changer. And I think, right, is that something that you've encountered as well?
When we reviewed our policy, we actually reviewed the literature, and we saw that there were studies published that showed that if you went straight from CPAP to room air, you decrease the amount of time on oxygen. So if you go from CPAP to high flow to low flow, you tend to keep the babies on oxygen longer.
And sometimes escalating oxygen.
Exactly.
Yeah.
So again, we looked for the babies who met our respiratory stability criteria, being on room air and being able to go straight from CPAP to room air successfully.
Cindy, thank you so much for coming by.
Yeah,
and for
thank
sharing
you. This was great.
This was great. Thank you so much.
Yeah, nice to meet you.
Likewise.